Hello, ladies and gentlemen. Thank you for joining our e-seminar today. We're delighted to have Dr. Leslie Allison join us to talk about CTSIB, mCTSIB, or SOT, when and why does technology matter. You may have noted that your line was muted on entry, and that's done intentionally to keep background noise to a minimum during today's presentation. If you have questions during today's presentation, will you kindly type them into the chat box located on the right-hand side of the screen, and I'll moderate those questions at the end of today's presentation. We do have a large audience today. Would you kindly refrain from unmuting your line during the presentation? That would be much appreciated. I'd like to introduce our speaker today, Dr. Leslie Allison. Dr. Allison is an assistant professor in the Department of Physical Therapy at East Carolina University in Greenville, North Carolina. She received a Bachelor of Science degree in Physical Therapy in 1979 from the University of Pennsylvania, and an MS in Motor Control and Learning in 1997 from Oregon State University. Dr. Allison is a PhD from the University of Maryland in May 2006. Dr. Allison has worked clinically, primarily in neurologic and geriatric physical therapy, with expertise in the evaluation and treatment of postural control disorders. Her research focus is multisensory integration, imbalance, and falls in the elderly. Without further delay, I'd like to go ahead and turn the presentation over to Dr. Allison. Dr. Allison, the presentation is yours.
Good morning, everyone. Thank you for joining me this morning. Thank you, Teresa, and thanks to Natus for giving me this opportunity to be with you all today and to share my enthusiasm about the benefits of a thorough evaluation of the different components of the balance system in order to best design and implement customized intervention plans for our patients. In a recent issue of the journal Physical Therapy, Romy Haas and her colleagues wrote about clinical decision-making in exercise prescription for fall prevention. They concluded, and I quote, "Physical therapists with expertise in fall prevention adopted an individualized approach to exercise prescription that was based on physical assessment findings rather than off-the-shelf exercise programs." We physical therapists pretty much all believe that patient outcomes are related to the quality of the interventions we provide. And the quality of our individualized exercise prescription is going to be based on our physical assessment findings. That means we want to use the right assessment tools so that we can get the information we need to identify patient problems and design effective treatment programs. Today, we'll be talking about tests of sensory organization for postural control or balance. These three pictures of Cirque du Soleil performers remind us how amazing skilled balance really is. When we see performers doing such feats, we tend to focus on the physical or motor skill of these people. But critical to that motor skill is sensory skill or perceptual skill, because balance is really a sensory motor process. It's perception that drives action. Correct action really depends on correct perception. So if we want to train our patients' motor skills, we must also train their sensory skills. These pictures look more like the everyday clinical scenes we are used to. The patients we see often have balance deficits. We tend to focus on testing and treating the motor skills of balance. But again, balance is a sensory motor process. And if we want to retrain balance, we have to retrain both the sensory processes and the motor processes. The motor processes cannot do their job well if the sensory perceptual processes are not working properly. Today we're going to be talking about the clinical test of sensory interaction on balance, or CTSIB. The original CTSIB was scored using a stopwatch. At the time, this was actually a huge step forward, a big improvement toward objective measurement from the time when we all just watched our patients and labeled their balance good, fair, or poor subjectively. Back then, there was no standardization of measurement at all. If you do not have a way to measure postural sway, like a force plate, then using a stopwatch is how you still score the CTSIB today. But if you do have a force plate, you can improve the sensitivity of your CTSIB measurement by doing the CTSIB with the patient standing on the force plate. As you'll see, this is of the greatest benefit for testing patients who do not have, quote, normal, unquote, balance, but who are able to score 30 out of 30 seconds on all the conditions of the CTSIB. I'd like to just briefly review the learning objectives that we're going to cover today. First, I'd like you to understand the vital purpose of the sensory organization test, often called the SOT, and the clinical test for sensory interaction on balance, often called the CTSIB or CTSIB, or affectionately known as the foam and dome test. We're going to also describe both the original traditional way to do the CTSIB using the stopwatch and the more current method of measurement for the CTSIB using the force plate. Then we're going to compare and contrast those two forms of CTSIB measurement in order to help you understand how to select the appropriate clinical test and measure for patients who might be at varied or changing levels of performance. Then at the end, we're going to apply the current force plate method of CTSIB performance measurement to patient problem identification, objective and quantifiable goal setting, and documentation of clear progress. At the beginning today, I'd like to talk to you about two important conceptual models that I use in my clinical practice and that I think are going to be helpful as we talk about where these tests fit in clinical practice. The first model is the enablement model, and this used to be called the disablement model, and now the World Health Organization has sort of revamped the model to give it a more positive spin, and it's now called the enablement model. And it has multiple components, each of which contribute to the eventual outcome of health, wellness, and lived quality of life. Really understanding someone's lived quality of life then requires multiple levels of evaluation. And we're going to look at that model and ask ourselves, at which level is balance? The second model is the dynamic systems model of postural control. And this model also has multiple components. And in this model, we're really concerned about how these components contribute to the eventual outcome of normal balance skills. Again, because there are multiple components, that means that if you really want to understand balance, you have to evaluate those multiple components. So then we're going to ask ourselves, in this dynamic systems model of postural control, under which area would we place the sensory organization test, or the CTSIB? Here's the enablement model, and what you see in the blue words, which are in the little boxes or ovals, is the current wording, the positive wording, and then underneath in the black, in parentheses, in the black text, you see the old wording from the disablement model. So up at the top, you see the term health condition. And this would be the person's diagnosis. So do they have diabetes, or have they had a stroke, or do they have Parkinson's disease, that sort of thing. That's the medical condition that the person would have. The next line, those three ovals on the next line, this is really where physical therapists live. We deal with impairments or body functions and structures, activity, and that can be either abilities or limitations, and then their participation in everyday life and the things that are restricting them or enabling them to participate in everyday life. I'm not going to talk a lot about the bottom of this model where there are contextual factors that influence their abilities and limitations to perform activity. Mostly, I'd like you to function on that middle line where we're looking at body structures and functions, or the impairment level, the activity that the person does, and the participation that the person can achieve in everyday life. So if we ask ourselves that question, where would we put the skill of balance? Pause, letting you answer, right? Well, I put balance in that far left-hand oval under body function and structure or impairment. So, but balance is the word itself is a little bit of a misnomer, as you're going to see in a moment, because balance is really not a single thing. It's really made up of multiple components, and that's why we're going to look at the next model. But when we talk about a balance impairment, that's why we're using that word balance impairment, because that's where it sits in this enablement model. The reason it's so important to thoroughly assess all the components of balance is because balance affects activity, our abilities and our limitations, and that affects our participation in everyday life. And I'm sure I'm preaching to the choir when I talk about that. Now we're going to talk about the dynamic systems model. And we could really spend a lot of time talking about this model, but today I'm just going to focus on the left-hand side of the model, which is the sensory perceptual side of the model. If you'll start on that left-hand side at the bottom, you'll see a box that says environmental interaction. And that's cues from the environment that are picked up by our sensory receptors. And then you see the three red boxes, and these represent our sensory receptor system, visual system, vestibular system, and somatosensory system. And these receptors are going to collect information, detect and collect information from the environment, and send that information up to our brain. And our brain is going to process, integrate, and here's your cue, organize that information. Your brain is going to compare the information it gets from those different systems and select the information that it thinks is important for what it needs to do, what you're trying to do at the moment. And it's going to combine as much information as it can possibly get in order to solve your balance problem. So what is your balance problem? Well, that's the next box further up. The balance problem that your brain is always solving every moment of every day is to determine your body position and motion in space. Where am I? And if you're moving, where are you about to be in the very next moment? So determining your body position and motion in space is the problem that your brain is constantly having to solve. So if we go back to that question that we were asking ourselves a moment ago, where would we put the SOT and the CTSIB in this model? Okay, we'd put, where would we place those tests if we were testing the different components in this model? We would place the SOT and the CTSIB in that purple box, compare, select, and combine senses. Because that box is where sensory organization is occurring, and that's what we'd be testing with the sensory organization test and the CTSIB. So let's talk quickly about the different boxes on that side of the model. What's the sensory environment? Well, the sensory environment is the conditions that exist or that we perceive to exist in the real world around us that impact our balance. Sometimes our perceptions are correct, and sometimes our perceptions can fool us. But our actions will always be based on what we perceive, whether or not what we perceive is correct. When it comes to balance or postural control, what our brain is very interested in is information about gravity, about the surface that we're on, and about the visual conditions around us. Surface conditions can include the surface that we're walking on, like an icy parking lot or a sandy beach. And visual conditions can include the absence of vision, like darkness, but also confusing visual conditions, like being in a moving crowd. We can't do a lot about changing gravity as physical therapists, although we do teach our patients to learn to manipulate their bodies in a gravity environment. But we can do a lot to manipulate the surface and the visual conditions. And that, in fact, is exactly what we do in the sensory organization test and the clinical test of sensory interaction on balance, is manipulate the surface conditions and the visual conditions. Let's take a look at this picture of a real-life surface and think about what the person's brain is doing while she's walking on this surface. The fact is that this person probably isn't consciously thinking about the surface because her balance is normal. Nonetheless, her brain has to take into account the fact that she's on an incline, not a level. The surface is bumpy. The surface is unstable, those rocks, that gravel can move underneath her feet. And the surface is also uneven. So there are many challenges on the surface that she is standing and walking on. And yet, because her balance is normal, her brain is solving that problem of detecting all those characteristics of the surface and taking them into account while she's probably thinking about something else and doing something else. That automatic nature of detecting sensory information and taking it into account and solving the balance problem of knowing where you are and where you're about to be in the very next moment, in normal people, that happens at a very subconscious level and doesn't require much attention. That's not always true for our patients. This slide looks like a picture of a surface because it's a stairway, but really I put this slide in here to talk to you about the visual environment. This stairway is in a hotel lobby, and I took this picture of the stairway because I noticed that when completely normal people were coming down this stairway, when they were coming around the bend, which is at the top right of the picture you're seeing, they would start holding on to the railing, even though they were young, healthy, completely normal people. So I took my camera up to the point where they started holding on to the railing, and I turned around and looked down at the stairs, and this is what I saw. Now, this is not the absence of visual information. In fact, there's a lot of visual information here. This is a very busy visual scene. But this visual information is not very helpful for postural control. This is a spiral staircase, so the stairs are narrower on our left than on our right. But that's difficult to tell with this carpet. It's also difficult to tell where the edges of the steps are and how deep the steps are. So visual information about the surface is obscured by this busy carpeting. So when the person's visual scanning of the surface ceased to be very effective in telling the person about the surface they were on, they would just naturally reach out and touch the railing to get additional somatosensory information until they got around this corner, and then they'd release the railing and come down the rest of the steps. So a problem with visual information sometimes is lack of information, but sometimes it's confusing visual information. The sensory environment can sometimes be stable and sometimes unstable. And this places different demands on the individual. If the sensory environment around us is stable, that puts a low control demand on us and on our patients. We get a lot of information from a stable sensory environment because we can couple our nervous system to these stable sensory cues in the environment. But when there are unstable sensory cues in the environment, when there's a lot of motion in the environment, for example, we can't couple our nervous system to all that motion in the environment, or we'll turn out to have a lot of motion. We have to uncouple from that motion in the environment, and that places a high control demand on our nervous system. We have to get our balance control then not from the sensory cues in the world around us. That's a much more difficult situation, requires a much higher level of sensory perceptual skill. When you think about this and you think about what we're doing in the sensory organization test or the clinical test for sensory interaction on balance, what we're going to progressively do from condition 1 up through conditions 5 and 6 is make the conditions less and less stable. We're going to remove visual information and we're going to make the surface, take away the firm surface and place them on an unstable surface. And so what that progressively does is increase the control demand. They can't take their cues from the environment anymore. They have to take their cues from their internal sense of postural control, their internal sense of orientation, and that is much more difficult. So what are these sensory receptors? We have somatosensory receptors, and we have lots of them. These are in our joints. These give us position sense and kinesthesia. We have somatosensory receptors in our muscles that tell us about muscle length and tension. And we have somatosensory receptors in our skin that tell us about touch and pressure. We have visual receptors. Obviously, these are our eyes. And our central vision helps us with orientation and navigation in space. Our peripheral vision is very motion sensitive and helps tell us about our own body sway. Our vestibular receptors, we have semicircular canals. These tell us about our head position and our head movement in space. And in the center, we have the utricle and the saccule, and these tell us about horizontal and vertical acceleration and deceleration of our head in space. These receptors, these sensory receptors, are located in our peripheral nervous system. And in the peripheral nervous system, they don't talk to each other at all. In the peripheral nervous system, your somatosensors and your vision and your vestibular system have no idea what each other are doing. But as soon as this information starts getting to the brain, very soon after this information starts getting to the brain, these sensory cues start being put together so that the brain can tell where we are in space. And that is sensory organization. Your brain starts processing these inputs that come in from your peripheral nervous system. And it has a big job to do. Your brain has to compare the information from these 3 different senses And also keep in mind that all of these senses, we have receptors on both the right and left sides of our body. And we'd like for the right and left sides to be providing congruent information, but that doesn't always happen, especially in patients with neurologic problems like stroke, for example, where there could be sensory deficits on one side that mix up information that the brain gets from one side versus the other side. So this processing of inputs from the periphery occurs in the central nervous system. It starts happening right away, very fast in the brainstem. It occurs at all different levels of the brain, including the midbrain and the pons and the cerebellum, up through the thalamus, and all the way up to very high-level processing in the cortex. So multiple levels of organization are occurring, some of it very fast in the brainstem, some of it taking a little bit longer higher up in the cortex. This processing of inputs from the periphery depends on whether or not a sense is available. So for example, if you've had an amputation, lots of the vets coming back from Iraq and Afghanistan have amputations, they might not have somatosensation from one or both feet left. So that sense might not be available anymore. It also depends on whether or not a sense is accurate. So a sense could be hypoactive or hyperactive and giving inaccurate information to the brain. And lastly, the brain has to take into account how valuable is this information for the task at hand. Do I need this information to do what I'm doing? For example, I can button a button on my sweater with my eyes closed. I don't need to look at that button to be able to button it. Okay. However, if I was really trying to navigate a crowded pathway, I really would need my vision for that. So how valuable is the sensory information for the task at hand? Your brain is trying to decide the value of information when it decides whether or not to use the information. Sensory conflict can occur when the three senses don't agree with each other, or when the right and left sides don't agree with each other. In the picture you're seeing now, this fellow's riding down an escalator. His somatosensory system is telling him he's not moving because he's just standing there. But his visual system tells him he's moving because he's experiencing visual flow, and his vestibular system tells him he's moving because his head is moving through space. So he has disagreement between his somatosensory system, which tells him he's not moving, and his visual and vestibular systems, which tell him that he is moving. Now, he's obviously not unstable at all because cognitively he understands exactly what's happening, and he's able to solve that balance problem. But sensory conflict situations in the real world can be problematic for many of our patients who have sensory processing problems. Resolving sensory conflicts is a perceptually challenging issue for many of our patients. They have to recognize which inputs are accurate and which are inaccurate, and they have to suppress the inaccurate input. In the picture on your left, the fellow is walking toward you, and the wall on his left is stable. So when he walks, he's getting visual flow going backward on his left. That cue is going to help him stay stable when the train on his right starts moving quickly forward toward you. When that train starts moving, that train is not going to be a helpful visual cue for his postural control. And his brain will want to suppress that forward visual motion of the train and instead pay attention to the stable visual cue provided by the wall. Now, this guy has pretty normal balance. He looks pretty comfortable in this situation. He doesn't look like he's worried he's going to be unstable at all. But you can bet if this person knew they had trouble doing this, they'd be edging their way over to the wall where they could touch the wall when that train started to move. So being able to recognize the accurate and reliable inputs and suppress the inaccurate inputs is a really important part of resolving sensory conflicts during sensory organization processing. Okay, this slide got all discombobulated, but what it says is that the job of your sensory organization processing is to arrive at the position of perception of the perception of position and motion in space. Your brain has to figure out where is your head, trunk, and limbs in relation to each other, where is your body in relationship to the environment around you, and what motion is occurring right now, because that motion that's occurring might influence where you will be in the very next moment. So this is just putting the model up again to review what we just did. We talked about the environmental interaction, cues from the environment. We talked about the three sensory systems in the peripheral nervous system that pick up cues from the environment. We talked about the sensory organization process that compares, selects, and combines those senses to figure out your body position and motion in space. That's the sensory perceptual side of this model. We mentioned previously that it's in that purple box, that sensory organization part of the box, where we might put the sensory organization test or the CTSIB test. That's the tool that we would use to assess this part of the model. So sensory organization is the ability of your brain to control your balance either when a sense is absent, in other words, when you're functioning with less information than you would like to have, for example, you're in the dark or your eyes are closed, or when the senses don't agree. In other words, you're in a sensory conflict situation like the ones we saw in the photograph. Examples could be you're on a compliant surface like a sandy beach, or you're in a situation where you have a lot of peripheral visual flow, like going down the aisles in a grocery store. A big part of what happens during sensory organization is called reweighting. And this is the process of your brain prioritizing that sensory information. Which senses are available? So for example, in the sensory organization test, sometimes we ask people to close their eyes or we blindfold them in the CTSIB, right? When we do that, we remove vision and vision is no longer available. We also have to prioritize which senses are accurate. Sometimes in the sensory organization test, the surface or the visual surround is sway referenced to the person's postural sway. In that case, the cues from the foot and ankle or from the eyes are not accurate. The brain has to recognize that those cues are not accurate and suppress them. And then the brain has to decide which cues are the most important for the task at hand. For example, in the sensory organization test, if the person is standing on a firm surface and the visual surround is sway referenced, and the visual surround is moving, but the person wants to hold still, then the brain should be able to say, hey, I'm standing on a very firm surface, the surface is holding still, and I'd like to hold still. So the cues from the surface are the most important for the task at hand. So I'm going to ignore or downweight the cues from the visual surround, and I'm going to pay more attention to or upweight the cues from the firm surface that I'm standing on. That's this whole process of prioritizing sensory information. The sensory organization test that I was just talking about was developed by Lou Nashner in the 1980s. It's a computerized force plate measure of postural sway. The task that the person is asked to do during the sensory organization test is just to hold still. So it's often thought of as a static balance task, meaning that the person is asked to hold still. Instead of asking the person to move around, we're going to manipulate the environment around that person. We're going to manipulate the surface and manipulate what the person sees. Subsequent studies have shown that this test, the sensory organization test, is very reliable with normal people and with patients with vestibular problems. It's valid in that it correlates highly with the dizziness handicap inventory. It's highly sensitive. That means it's very good at detecting abnormalities, and it's specific. It's able to isolate patients who have balance problems because they have somatosensory impairments from patients who have balance problems because they have vision processing problems from patients who have balance problems because they have vestibular impairment. That's going to be an important difference between the sensory organization test and the CTSIB. The sensory organization test manipulates vision by having your eyes open in a stable visual surround, in which case your vision is available and accurate, by having your eyes closed, in which case vision is unavailable, or by having your eyes open when the visual surround is sway referenced. For those of you who may not be familiar with the term sway referenced, what that means is that the force plate the person is standing on, which you can see in this picture, is measuring the person's postural sway. And the sway of the person will determine the sway of the visual surround. In other words, the visual surround will only sway if the person is swaying. That's why we use the word sway referenced. The sway of the visual surround is referenced to the sway of the person, which is detected by the force plate. When that happens, what the person is seeing is inaccurate visual information relative to their actual postural sway. So that it creates a visual sensory conflict that that person's brain has to solve. In the sensory organization test, we can also manipulate the somatosensory system. We can have the surface stable, in which case somatosensory cues are available and accurate, or we can have the surface sway referenced. Just like the visual surround was sway referenced, the surface can sway if the person sways. When that happens, the brain has to recognize that the cues from the ankles and feet are inaccurate, and the brain should suppress those cues and instead pay attention to cues from other available and accurate senses. If both vision and somatosensory cues are simultaneously manipulated, then the use of vestibular inputs can be isolated. So in the two final conditions, when the eyes are closed and the surface is sway referenced, that means vision is absent and somatosensory cues are inaccurate, or the eyes are open and both the visual surround is sway referenced and the surface is sway referenced. That means both vision is inaccurate and somatosensory cues are inaccurate. In both of those conditions, only the vestibular inputs remain available and accurate if the person has a normal vestibular system. So this slide just shows you exactly what I just talked about. It's just sort of a summary slide that shows you that in condition 1, I'll just move my little cursor down so you can see here. In condition 1, all three senses are available. In condition 2, the eyes are closed, so vision is absent. In condition 3, the eyes are open, but the vision is inaccurate. In conditions 4, 5, and 6, the floor is sway referenced. So in condition 5, the eyes are closed and the floor is sway referenced. In condition 6, the vision is sway referenced and the floor is sway referenced. So in conditions 5 and 6, the only remaining accurate sense is vestibular. This is the sort of report that you would get from the computerized sensory organization test. On this, I'm going to try and use the little highlighter here. On this scale, over here, is the relative stability of the person, 100 being the most stable and 0 being a fall. So you see the 6 conditions across the bottom, and you see how stable the person was. If the bars are green, that means that their postural sway was low, their stability was high, and they scored in the normal range. If the bars are red, that means their sway was high, their stability was low, and their bars are red because they scored in an abnormal range for their age group. This slide shows the sensory conditions evaluation of a patient that I treated for 16 sessions, twice a week for 8 weeks. And it shows that the SOT does discriminate between fallers and non-fallers. This person was a faller and is responsive to change over time. And that's what I wanted to show on this slide. You can see that the SOT did show that he had difficulty in any condition where the surface was unstable, and that he fell on all 3 conditions where his eyes were closed and the surface was unstable. That was on his pre-test. But that after 16 sessions of balance retraining that included multisensory retraining, all his bars were in the normal range. And it's with this sort of computerized testing and this computer-generated report that it is very easy to demonstrate clearly the progress that you make with your treatment. The CTSIB is the clinical test for sensory integration in balance, and it was developed by Anne Shumway-Cook and Faye Horak in 1986. These are both physical therapists. Anne Shumway-Cook and Faye Horak are physical therapists, and they wanted to develop a low-tech test that physical therapists could use because physical therapists at the time did not have much access to force plate testing. It uses foam in place of a sway-referenced force plate and a Japanese lantern in place of the sway-referenced visual surround, and measures with a stopwatch. The task that the patient does is just the same, to hold still. And just like in the sensory organization test, we're going to manipulate the environment. This test has been found to be reliable with normal individuals and patients with peripheral vestibular problems, but is not reliable in patients with stroke. This test is sensitive to, quote, sensory balance abnormalities, which means it's a good rough screening test to tell you if someone's abnormal or normal, but it's not specific enough to distinguish sensory loss patterns. In other words, it's not great at distinguishing who has a somatosensory problem versus a vision problem versus a vestibular problem. The original CTSIB substitutes foam for a sway reference surface, and a subsequent study shows that there's a pretty good correlation between those two things. It substitutes a Japanese lantern for the sway reference surround, but that subsequent study did not show much correlation between the lantern or the dome and the sway reference surround. So many people no longer perform the 2 conditions that include the dome, and we'll talk about that in a moment. Some people use 3 trials in each of the 6 conditions, and some people do 5 trials in each of the 6 conditions. The original CTSIB had 5 trials in each of the 6 conditions, but most clinicians are pressed for time and just do 3. The patient stands with their arms crossed or their hands on their hips, and the therapist measures the time up to 30 seconds in each condition until the patient steps, reaches, meaning they uncross their arms or they lift their hands off their hips, or starts to fall, or until their eyes are opened in the eyes closed conditions. The original CTSIB had 6 conditions just like the SOT does, and I'm sorry this didn't scan in very well, but you can see that in the top 3 conditions the person stands on the floor. In the bottom 3 conditions, the person stands on the foam. In the 2 left-hand conditions, the person's eyes are open. In the 2 center conditions, the person stands with their eyes closed or with a blindfold. And in the 2 right-hand conditions, which is difficult to see on this slide because of the overlay, the person stands wearing the Japanese lantern. These conditions are all timed with a stopwatch up to a maximum of 30 seconds in each condition. The modified CTSIB keeps the foam but not the dome, based on the research showing that the foam correlated highly with the sway reference surface, but that the dome did not correlate very highly with the sway referenced visual surround. So the modified CTSIB eliminates the 2 conditions with the dome, which were conditions 3 and condition 6. The hypothesis was that the dome didn't work well because it was attached to the head, and when the head moved, the dome moved, and that allowed the brain to recognize that the dome really wasn't the environment and suppress it, much the same way that we learn to suppress the image of our eyeglass frames very quickly when we first wear eyeglasses. The other hypothesis was that the image of the inside of the dome was too close to the eyes to be perceived as the world around us, to be perceived as the environment, unlike the visual surround, which is much further away. So the modified CTSIB includes conditions 1 and 2 on the firm surface and 4 and 5 on the foam surface. And this slide just shows a picture of a person on the foam on the force plate. And then the bottom of this slide shows the 2 conditions on the force plate, which are firm surface, eyes open and eyes closed, and foam surface, eyes open and eyes closed. This next slide, I'm sorry that it's blurry. This is just how the image imported, but it gives you a rough picture of what the computerized report from the modified CTSIB looks like when you do it on a force plate. And what you see up on the top are each of the trials in each of the 4 conditions. Conditions 1, 2, here it says 1, 2, 3, and 4, but they're actually conditions 1, 2, original condition 4 and original condition 5. So you get to see the postural sway in each trial of each condition, and then down below on the left you see how well the person did compared to normative data for their age group. So this is something that you do not get if you're measuring just with a stopwatch. Again, if the bar is low, that means their sway was low and their stability was high. If the bar is high, that means their sway was high and their stability was low, and they scored outside the normal range if their bar is red. This graph is from a research paper, a study paper, that used the exact same conditions and looked at males and females, which is unimportant for our talk today. But I just liked this graphic because it shows you what you cannot see with a stopwatch. In this particular study, they timed people for 90 seconds, not 30 seconds. But you can see that each of these subjects stood for 90 seconds in each condition. So if you had been using a stopwatch, the score for each of these 4 conditions would have been exactly the same, 90, 90, 90, and 90. And yet by using a measure of postural sway, you see big differences between how well the person was able to solve the balance problem in each of those conditions. And that's the benefit of having a postural sway measure when you do the CTSIB. The addition of a postural sway measurement allows clear discrimination in performance between the conditions. This slide is an example also from the study I did where we treated people 16 times, twice a week for 8 weeks. And this is one of the patients who was in the study who was a repeat faller. And this is their CTSIB condition 5 performed on a piece of foam on the force plate at their pre-test and their post-test. Now you can see even at their post-test, they're not normal. Okay, this was an elderly person who had a lot of falls, but you can see that even at their pre-test, they were able to stand for the whole duration of the test. So if all I had had was a stopwatch, I would not have been able to show any progress over the 8 weeks. They would have gotten exactly the same score on week 8 that they had gotten on week 1. And yet, because I was using the force plate measures, I was able to show this large degree of improvement over time. And so, again, this is the benefit of having a more sensitive measure when you do the CTSIB. Other studies have also shown that force plate measures offer better fall risk prediction than typical clinical tests do. I'm just listing 2 of these studies here. I'm not going to talk about them in detail. The references are listed here. You can go and read these studies. One of the things I thought was very interesting was these studies were done completely separate from each other at different locations, different points in time. But both of these authors found just about exactly the same thing. And both authors found that the addition of clinical measures to the force plate measures did not improve fall risk prediction. So the force plate measures gave them their best fall risk sensitivity. So if you have a force plate to measure postural sway, that's what's going to help you more than clinical measures alone. So why would we really need the force plate? If you are working with a low-level patient who is going to get a score of 10 on the pre-test when they do the CTSIB, and they're going to get a score of 20 on the post-test, you're going to still be able to show progress without the force plate. The force plate is the most beneficial with high-level patients because these are the patients who can top out on easy balance tests, and that makes it difficult to show whether or not they have any abnormality and to demonstrate any progress due to treatment. The CTSIB is a static or hold still test, and it asks people to stand with their feet apart. So it is a pretty easy test for higher level patients. Higher level patients may certainly be able to stand for 30 seconds in each of these conditions, but that doesn't necessarily mean they're normal. And a more sensitive force plate measure may show that they have excessive sway within that 30-second time frame in one or more of the conditions. So the force plate might show that they're abnormal when the stopwatch measure doesn't indicate that they are. And the force plate can also demonstrate improvement over time. In other words, that their sway is reduced over time as a result of your treatment. When, if they had scored a 30 at the pre-test, you would really have nowhere to go in using that test to show that your treatment was having any positive effect. So just a quick slide to give you a feel for the measurement quality that we're talking about. Certainly, doing no measurement is completely unacceptable. The old way we used to do things of just labeling people good, fair, poor was totally subjective and non-standardized, and that's no longer acceptable. Using a stopwatch, if that's what you have, is certainly better than what we used to do, and if that's what you have, you should keep doing it. But if you have the opportunity to use a force plate, that is going to give you more sensitive measures and is, for obvious reasons, I think what are now obvious reasons, a better way to measure if you're doing the CTSIB. This slide just sort of summarizes what I have just said. The stopwatch is objective and is better than not using a stopwatch, and it's most suitable for patients who are unlikely to achieve the 30-second time limit in all trials of all conditions. The foam, the compliant surface, is most suitable for patients without biomechanical orthopedic problems in their legs and feet or without motor control problems in their legs, ankles, and feet, because the foam is difficult to stand on. The force plate is objective plus sensitive. It's suitable for these higher level patients, which I have certainly already explained. And the firm surface of the force plate compared to the foam is more suitable for patients with biomechanical or orthopedic problems in their legs, ankles, and feet, or with motor control problems in their legs, ankles, and feet. And that's something that makes the sensory organization test, although it's a more complicated piece of equipment, that makes it better for these sorts of patients. The case study, just real briefly, I know we're wrapping up, that is a person that we saw in our fall risk assessment clinic. She's female, 69 years of age, very active and independent in the community, but she brought herself to the fall risk assessment clinic because she senses she's becoming less steady when she's walking than before. She hasn't had any actual falls, but she has had several near falls, especially when she's hurrying or dual tasking. Her clinical test, her 5-time sit-to-stand test was 11 seconds, not too bad. Her time to get up and go test was 9 seconds, not too bad. Her dynamic gait index was 23 out of 24, very good, only slightly unsteady, walking with head turns. Her Berg balance scale was 54 out of 56, again, very good, only slight problems on the 2 highest level activities. And just timing her CTSIB, she scored perfectly, 120 out of 120, 30 out of 30 on all 4 of the modified CTSIB conditions. But if we put her on the force plate, we can see that although she scored normal postural sway on the firm surface conditions, she had abnormal postural sway on the 2 conditions with the foam. These were more difficult for her. And so we were able to set these objective quantifiable goals for her based on those force plate measures. So we could say within 2 weeks we wanted her to have reduced sway with eyes open on the foam, scoring within the normal range for her age within 2 weeks, and within 4 weeks that she's demonstrate reduced sway with her eyes closed on the foam, scoring within the normal range for her age within 4 weeks. So having the force plate makes it very easy to see that she was abnormal even though her time scores looked normal, and makes it easy to write objective quantifiable goals. And then it's easy to see the clear progress she makes when you compare those CTSIB reports pre and post intervention. Because she's over 65 and is a Medicare person, for the physical therapist treating her, the concurrent goals and documentation would, of course, always be related to functional abilities so that Medicare coverage would be provided. I always use the sensory organization test or the CTSIB within a comprehensive balance test battery to obtain a complete picture of the patient's balance system. I never use just the SOT or CTSIB. I always do other balance tests as well. This is an example of a great balance test battery called the BEST test, which has been developed by Faye Horak and colleagues, and the reference is down at the bottom of this slide. And we don't have time to talk about this test today, but you can see that the CTSIB, I'll turn a little highlighter on here. Here's the CTSIB here as a part of this balance test battery. I have to say thank you very much for your time today. I really appreciate your interest in this topic, and I know all of you are listening to this topic because you are treating patients with balance disorders, so I'd just like to thank you very much for everything you're doing for those patients with balance disorders. I know you're making a big difference for the people that you treat.
Dr. Allison, thank you for that excellent and amazing presentation. For those of you who are attending, we'd like to thank you for taking time from your day to attend today's e-seminar. This will conclude the recording of today's presentation, and as I mentioned, I will be sending you the recording link within about 24 hours.